Oh, hey, Chris.
Hey Chuck, how are you?
I'm really good, really good. Sunday afternoon, a week ahead of drop date for our pod. We're feeling good.
I know we are on top of this. It has been such a nice weekend to relax here.
Has it? What have you been doing?
It's so nice. Like we didn't have any major obligations. I got to have Tiffany took the kids to the outdoor theater to the Muni on Friday night. They had a rain delay, but that meant I got a nice little night to myself just to hang out, and I enjoyed that. And then yesterday got to play some tennis, which was super fun. Some friends kindly offered to take the kids to a water park. So Tiff and I had some time just to hang out, get some stuff done, and relaxed. And yeah, it was great. And then I binge watched 5 episodes of The Bear last night, which was awesome.
And what's
So
the review? I heard I'm not a watcher, but I heard season three was not as good as season two. But what's the early verdict on season four?
I haven't gotten through all of this season. I really like it though. I just like I think about what I might do in the future. And I was like, maybe I'll just go work in a kitchen. This in the back half. But anyway, it's been great and just to get the time to chill. And uh, today, a nice relaxing morning, and had a luxuriously long workout, which is always nice. And getting ready to we're having some people over for some barbecue. I'm gonna celebrate July 4th early since I'm on call, and I probably won't be doing much celebrating.
That's very wise, very wise. We had a house full of guests this weekend. Talia's brother and his family came over from Providence, which was delightful. But it's very different from our normal MO these days, where well, usually it's empty nest, just Talia and I, and then having my daughters back in town in the house changes the dynamic, of course.
Right?
Having a house full of people is a whole other thing. I'm a little
Yeah.
bit like I need to go back to work.
That's all. But that's our lives. It's always a house of people. Well, my parents were in town for a couple of weeks for my birthday, and for my daughter had dance recital and a ballet, a piano recital and a dance thing. So they were in town for that, and then they extended their stay for my birthday, which was really kind of them. So yeah, it was a busy house. And then when they left, I was like, oh, it's quiet. Like we're just sitting here, the four of us having dinner again.
Talia thrives on a full house, and Kylie has a bunch of friends coming in next weekend for the fourth, so that'll be fun. Different neediness and different interest in interacting with old people like me, but fun. But I want to touch on something you mentioned, your birthday. I heard there was a unique contest slash celebration for your birthday.
Well, okay. If anybody knows anything about me, it's that I often eat in excess, and I have very much like competitions. So to combine these things, we started it last year. Now that it's been 2 years in a row, it's an annual tradition. We do a pizza potluck. So we had a number of friends come over. I think there were, about 8 or 9 different families came over, and the job is the ask is to bring your favorite pizza pie from the area, and see which one wins. And we have last year and this year, Dr. Marshall Burks and Dr. Ryan Nunley kindly offered to be the ones to reheat and serve the pizzas so that everybody else was supposedly blinded. There's a scoring sheet. The scores were tallied, and I was very full and very happy at the end.
So, are there any guidelines? Like you tell your guests, do like, guests have to sign up for a certain pizzeria so no one brings the same pizzeria, or is it just
Yeah, so
assumption?
there's a lot of coordination that goes on. Tiffany kindly organized all of this last year and this year, and didn't put me on a text thread until after it was done, so I didn't know who was bringing what. And I think last year we did either had I think it was a cheese or a pepperoni. I think we did pepperoni last year, and then this year is interesting because it's introduced a lot of variability. It was a supreme pizza entry from each
Whoa.
place. Yes.
And all your guests enjoy Supreme Pizza, or else tough luck. Like either
Yeah,
enjoys.
well, there was a couple of extra pizzas, quote, for the kids, for that were just cheese, and then some pasta for the kids and stuff. And there was a salad that eventually people ate once they felt the need to take a break from the pizza to detox. It was a lovely afternoon. It was really hot, but it was super fun.
So most of our listeners will not be interested, but I am. What was the winner, if you recall, for St. Louis pizza pies?
So this is interesting. And I'm surprised somebody brought this, but they brought in a national chain. Mellow Mushroom came in first.
Wow.
So that was really that. I mean, I love a mellow. I mean, I love all pizza. I'm not gonna lie. But mellow mushroom came in first, and Jets, which I believe is Detroit style pizza. I'm not sure it's actually from Detroit. That came in second, and then came in third was Fortel's, which is actually from St. Louis. So yeah, I mean, there was a lot of, and then there was one entry in the middle that was brought by Dr. Lindley Wall and her husband Fred Stivers from Blackthorn, which is a small bar, from what I understand. I think it's in South City, where it takes forever to get a pizza because they have just one small pizza oven, and that thing was thick. It was polarizing. So we have to find some statistical way next year to get rid of the outliers. But people either loved it or hated it. So that I think that was the most interesting entry, and you will be pleased to know that somebody snuck in some Dominoes, and it came in a solid number 7 out of 10.
So there's real judging quality here, I think is what you're saying. And I would say add this, I am friends with the owner of the franchises of Mellow Mushroom. I think there's an opportunity for publicity here
Okay.
for your gang.
Or I think if they want to sponsor the pod, clearly that is a nice opportunity for them. So give us a holler. We are looking for another sponsor, so let us know.
That is great. Well, that's a wonderfully unique way to celebrate, and it does sound like a tradition after 2 years.
I think so. We did it, and, my birthday happened to fall on a Friday, and so we did it on Father's Day. So it was kind of like a Father's Day birthday type celebration, which was super fun. So cheers to all the entries. And again, there are still some leftovers in my freezer. So
So, probably a good time to thank a sponsor before we shift gears. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
becoming a physician is hard. Finding the right job doesn't have to be. Visit PracticeLink at www.practicelink.com/the upper hand.
So, um,
I did that completely by memory, by the way. I didn't even look at the chat.
I
I just went
mean,
for it.
we should be able to. How many episodes? A lot.
5 years, five and a
Yes.
half years.
So, our topic today is a good one. It might sound rudimentary, but I think we're going to make it fun. And it's important that we share where we got this idea.
Absolutely. So if you haven't checked it out yet, first off, get on our mailing list because we're sending out a survey. And the survey is really helpful for us, helps us understand what you guys want to hear, what you like, what you don't like, what topics we should revisit or visit for the first time. But then also, you get a chance to win some very coveted swag. Now, I think there's still a couple upper hand coffee mugs that are available, but even more interesting, there is an upper hand backpack, limited edition. It's I don't know how to pronounce it. The OGIO,
I don't know.
sweet backpack. So if you're interested in getting one of those, please fill out the survey. At some point, we'll do a raffle of some sorts, and then we can send that out to you. So thank you for the feedback. And Chuck, why don't you tell us about the topic we're doing today?
Yeah, before I do that, I want to say that if you aren't on the mailing list, yeah, you can join. You can see how in the show notes. Also, the show notes will contain the link directly to the survey. It takes 3 minutes. It's easy. And it's actually, we're going to use the results to make a better podcast because we want to know what resonates with each of you. So thank you for taking the time. It's really important. And I think we'll share some of the results. And I think our goal should be next week, next podcast, we can do the raffle and share some of the winners, and that'll be fun. So today's podcast is about the carpus. And, you and I take the carpus for granted. I remember a day when the carpus was confusing and scary, and I was learning ossification patterns and ligaments and all of that. And we can get into a little of that, but I think it's a kind of a cute topic.
I think it is. We could talk about some neglected bones in the corpus that don't get any love because
Exactly.
everybody always talks about the scaphoid and the lunate. But there are it's not a lot of love for the trapezoid out there. So why don't we jump in?
Well, let's start with the trapezoid because I was thinking beforehand, which is the least discussed bone, and I don't think it's close. It's definitely the trapezoid.
Yeah, nobody talks about the trapezoid. So the only time I think about the trapezoid is when I'm doing a thumb CMC, and if I'm doing it from a dorsal approach and I'm doing some kind of suspension, uh, I just look for that, and then I go find my second metacarpal just beyond it. There have been times where I've put an anchor inadvertently into the trapezoid instead of the second metacarpal. Had no effect clinically, but that and the other context I think about the trapezoid is for STT arthritis.
Yeah, all good points and the same ones I think about. I think about the trapezoid, and I think hopefully we're going to have some pearls in this kind of seemingly odd discussion, but I think about the trapezoid exactly as you do. I think about it when occasionally there's a second carpometacarpal joint issue. That's pretty rare. I think about it when there is STT arthrosis in addition to CMC, and then I look over and think about, do I need to do something with the trapezoid metacarpal joint? I may have told this story before. I was at a Peter Stern reunion, and those were every 3 or 4 years. The fellows would get together in Jackson Hole, still going on. And someone showed a picture of what they call a distal carpal, instead of a PRC, a DRC. And because they took out both the trapezoid and the trapezium, and it was especially funny. It doesn't sound funny right now, but it was especially amusing because Stern is known for proximal carpectomy advocacy. I will have to say he was not an advocate for the DRC.
Ah, okay. What would be the indication for the DRC?
I don't think there is one. I I think if I was going to take out part of the poor trapezoid, it would just be to address severe arthrosis in the setting of STT arthrosis.
So how much do you take out?
This is very precise. I take out a rongeur width. What about you? What do you
Depends on the
do?
rongeur.
Yes, for sure it does.
So in all seriousness, if you leave that kind of raw cancellous portion of the proximal trapezoid there, is that a big deal to have that in proximity to the remainder of the nice shiny cartilage there, distal polus scaphoid? Like, is that a big deal?
I don't think so. And knock on wood, when I've had to do this or felt I had to do it, it's a little non-scientific. It seems to have resolved the issue.
Now, how often do you see a trapezoid fracture?
Super rare and usually part of obviously a bigger trauma situation to the carpus, whether it be a gunshot wound or something like that. I don't recall
Fourth
ever
of July
having.
fireworks.
You're already getting anxious about this upcoming
Oh
weekend.
yeah.
Yeah. Huh.
How often do you get index CMC instability issues or pain?
Um, Quite uncommon. I've had to address it a few times in my career, and I've actually have an active patient right now where I've done a CMC fusion, and without any seeming effect on function or anything like that. But I have done fusions of that joint. It's just incredibly uncommon.
The only CMC joint I've fused, aside from the thumb, is the fifth. In a setting of post-traumatic arthrosis, which if you read Green's the chapter on this, they quote that quote never happens and they never come back. But you get a straggler. I think I've one scheduled soon. That's going to be the second in my 10 years of practice.
Nice, impressive. I just hit a new barrier. I just finished my 23rd year. I know that from my surgical log. So a little
Wow,
different stage. Yeah.
wow, wow. So would you ever fix a trapezoid fracture or pin or
I I think we've given the trapezoid enough love, but to answer your question, I guess I would if it was displaced enough.
This is the most anybody's ever talked about the trapezoid. Like it has never been discussed at any meeting, any other educational venue. The last 3 minutes of trapezoid talk, it must be a record.
Let's move on to the capitate. I'm going
No, no, no,
clockwise.
no, hold on. I want to ask you before we do more. Do you have a favorite bone in the carpus?
Um, that's a great question. I mean, my God, it'll keep you up at night wondering what your favorite bone in the carpus is. Because of all the trouble it causes us, it's got to be the scaphoid, both my favorite and my least favorite simultaneously.
I'm going hamate. I'm going
All right.
hamate.
All right, well, don't jump. Let's go to capitate, then we'll get to your
Okay,
favorite bone.
fine, fine, fine.
So, when is capitate relevant to you?
Well, I mean, in the context, I guess, of a PRC, so evaluating the base of the capitate. I can think about it in the context of avascular necrosis of the lunate, because there's folks that are doing that crazy capitate shortening thing. Um, Not crazy. I just haven't done it yet. I guess that's the majority of the times I think about the capitate. Hmm. I guess
Yeah.
sometimes I use it as a target when I'm pinning stuff. Like if I'm trying to stabilize fourth and fifth CMCs, it's a nice big bone. I don't know. What do you think about it?
Those are exactly what I would say. Like it is a great place to put a K wire if you're, doing a 4-5 or even if you're pinning a scaphocapitate joint,
Yep.
either temporarily or more than temporarily. The oddities, I have seen capitate AVN. So that sometimes, I guess, again, super rarely needs to be addressed,
Maybe
but
too many K wires.
maybe too many K wires. Yeah, the capitate. The other time I think about the capitate, I know exactly when. When I'm doing an open approach, and comes up all the time. So you're doing an open approach with a resident
I
for,
know exactly
say,
what you're going to say.
yeah, say for a ganglion cyst excision, and you're looking for the SL ligament and the origin of the ganglion. The dorsal capitate, just distal to the cartilage, has a really 100% identifiable appearance with that sort of bare bone, and you know it when you see it every time.
It's interesting because I thought where you were going to go with that is that I think Marty Boyer would say that whenever you think you are radiocarpal, you're actually mid-carpal because you're looking at the capitate.
Well, I think I am saying that, but that unique appearance of
Right.
the proximal dorsal capitate is one, and you feel really good. You're like, no, 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 you're at the capitate, and they're like, how do you know that? I'm like, trust me, it is.
Pattern recognition over 23 years of
That's
practice.
right. It's a lot of years.
So, when would you fix a capitate fracture? Do you, because you sometimes get those kind of shearing or sagittal plane type fractures, right?
Yes, it's quite uncommonly with a perilunate, a greater arc injury, so to speak. You can see them. You can see them in isolation. Usually, again, part of another pattern in K-wire fixation. And certainly, there's nothing wrong theoretically with like a retrograde headless screw. But I can't, maybe once or twice in my career, have I fixed a capitate fracture? Have you?
I have not. I also think about the capitate in the context of a four-quarter fusion. Because I think that paper that I think you were on that paper with Jim Calandruccio and Dr. Gellerman, and I think Marty was on the paper too, but talking about the importance of the capitalunate portion of the four-corner fusion.
Yes, and I think we've talked about this. I have at some point in my career, I signed up to be notified when I'm cited, and so every so often, I will get an email most days. It says you were cited on this paper or whatever. There's a new paper somewhere, some journal, talking again about the isolated capitolunate fusion with excision of the scaphoid and the tracheatrum. All these carpal bones are like, getting a lot of airtime. So yeah, that
Bones you
paper
can
lives
swallow.
on. That's right. All right, let's get to your favorite bone. There's a lot more to talk about. The hamate.
So the hammate's interesting. I think about it in the context of CMC and stability, and having to pin that and that subtlety of, I think Ryan Calfee was the first one of the WashU faculty to teach me to use that, oblique views to really find the subtle CMC instabilities in setting up a fracture dislocation of metacarpal base typically. Um, I think about it then, obviously, I think about it with regards to the ulnar nerve. You probably like that bone too
Always.
because of the hook and all the sportsiness and batting and whatnot. But then, what about when do you ever fix a hamate fracture that's not a hook fracture, like hamate body?
Right. Again, well, all good points. And the hamate's a super interesting bone. Again, I'm
It
not
just looks
sh
it looks cool. I
It's
mean,
cool. I mean, who's got a hook and a body, and yeah, it's got a lot going on. It's got an avascular area. It's a
Mm-hmm.
lot, a lot. So I do agree that 4 or 5 CMC fracture dislocation, if that dorsal piece is big enough, I will open, and pin the joint or joints, and then fix that fragment with a little screw. I think that's very satisfying, and when it's big
That
enough,
is
very important.
indeed very satisfying. Uncommon. I mean, I guess this is of the bones that we've discussed so far. This is the most common one to have a fracture and subsequently have surgery.
Yeah, it's leading the way. It's definitely the number one right now. And we've
Oh,
talked,
let's not forget about the hemihamate arthroplasty.
who could forget, although I did, the hemi-hamate. I mean, that's one of my favorite operations. Great, great point.
Do you really do you think that operation does as well as people say it does?
No, I think that operation has the potential to be a home run and a game changer for certain patients, but is not a panacea for all that ails the PIP joint.
It is it's when it when it's great, it's great. When it's miserable, it's miserable. I
Yeah.
still remember. I think I told this story on the past episode. I remember the first one that I was supposed to do in practice. I was nervous about it, so I had our partner, Ryan Calfee, do the case with me. Fortunately, we harvested the volar plate just in case. Didn't work out so well for the hemi hamate that day, unfortunately. Despite our best efforts at excellent carpentry, it just didn't work out. So always, I learned a lesson to always have your backup available. So for us, it was a volar plate arthroplasty.
Yeah, which a lot of listeners are going to say, what is a volar plate arthroplasty? And that is not the point of this episode, but it is an interesting teaser for a potential future episode.
Yes, things that do well. PIP fracture dislocations.
Yeah, another wonderful topic. And we've talked about, haven't we, for the pod, hook of the hamate excisions? I would assume we have.
I think we've talked about it. I guess I have an interesting patient. From recent times. Just persistent pain at the hook of the hamate. X-ray negative, MRI negative. Just continues to have pain, neurologically intact, focal pain, palpable right over the hook. What do you tell them? Like, how much longer do you think that's going to take to resolve?
I mean, well, I wonder, a fall and an outstretched hand can
Mm-hmm.
cause, we're going to get to this later, trapezial ridge fractures and hook of the hamate pain. I've seen it take 4 to 6 months.
Okay.
And then after that, you can think about being more aggressive.
Yeah, it's just hard when there's nothing on the, no signal change on the MRI to then say, all right, well, let's talk about surgery. But
Yeah,
yeah, we're gonna wait it out a bit longer.
absolutely. That is good.
Do you ever
Um,
fix hook of the hamate fractures, or there is some literature out there about this? I think it's crazy, but would you ever do that?
Yeah, I mean, there's three treatments for hook of the hamate fractures. One is excision, which is clearly the treatment of choice. I would say that pretty strongly, clearly the treatment of choice. I have never fixed a hook of the hamate. That certainly is supported by some literature. It just doesn't make sense. You're treating a fracture of a bone that you don't need in an area that's hypovascular, so it just doesn't make sense. And people talk about casting. Now, occasionally in the right patient, it might make sense to cast, but again, pretty rare.
Okay. Well, before we move on to the proximal row, we should acknowledge our friends over at Checkpoint. So surgeons know Checkpoint Surgical for their monopolar nerve stimulator, Guardian. That's the blue one. But did you know they have a bipolar nerve stimulator called Gemini? I call that the purple one.
With a bipolar stimulation probe, Gemini provides finely controlled stimulation, even at a fascicular level, and is an ideal stimulator for selective neurectomy for spasticity. Want to know more? Visit checkpointsurgical.com. Wow, I mean, interesting concept.
Uh,
Fascicular level stimulation.
you just wanted to say that again, didn't you? I
I
used I
did.
used the purple one. I used the purple one in the OR the other day. It allows me to move much more quickly, which is not the point of using the purple one. But the purple one, because it's bipolar, you don't have a grounding lead. In addition to the ability to have that kind of extra level of uh, refined touch, you just don't have to keep taking the lead in and out and potentially stabbing yourself or anybody on your team. So I enjoy that part of it.
It's important. Let's keep going. We're on a roll. What about the smallest of all the carpal bones, the pisiform?
I think this one gets a little love though. I feel like, like it's part of the exam for me for ulnar sided pain. I pretty automatically just kind of move through that and do the piezo triquetral boost test. I think that it's a joint that can cause pain and can nag people. So that's pretty much the only context in which I think about the pisiform, except if I'm on my way to treat, with regards to the FCU. But
Yeah, I think the pisiform is indeed an interesting bone. You can have pisotriquetral arthritis, and that should be on everyone's differential for ulnar-sided pain. That's interesting. You can have in a younger patient, an athlete, you can have subluxation or dislocation of the pisiform, and you can
how
have
often does that
pisiform
come up?
fractures. Not
How
not
often?
commonly,
Okay, I
not
was
at
like, I
all.
don't see that. So
Yeah, not at all. And then you can have fractures, which again, super uncommon, but can't forget about it.
would you fix them?
Um, I guess again, if it's I haven't done it. If it's displaced enough, or you just take it out.
Yeah, that's probably
Whenever that's an
that's probably
option.
really leaning into the hand weaniness of this whole thing.
Yeah, it is an interesting bone though. I mean, I will say this. giving a piezo tricuetral injection can really be helpful. I've done that recently in a professional athlete and got him back to play pretty quickly after weeks of issues. When it comes to excising the piezoform, and so I guess let me go back. That was a treatment for tricuetral inflammation and joint-based pain. So interesting. That's also uncommon. But when it comes time to excise the piezoform, which I think we all think, oh, let's just take it out. It's a bigger bone than expected, and it's a bigger surgery than expected, but really gives good results in my experience.
Yeah, I think I've done one for for arthritis. Usually, my mainstay is to do an image guided injection. Given practice flow, I usually send them to physiatry for an ultrasound guided injection. And then now I know that it's in the right spot. Although we could clearly do it on fluoro in clinic, and I don't know if you use image when you do it or not.
Yeah, I don't want to sound overconfident, but I will do a freehand injection and feel pretty good about it. I think you can really feel that joint in yourself. You can feel the kind of the sulcus there, and I think it's injectable freehand, but I certainly wouldn't be critical of an ultrasound or image guided injection at all.
Has anybody ever talked that much about the piezoform?
We're up there. We could be leading the way for podcast discussion of the piezoform. So let's move on.
Ah, yes,
Tracheatrum.
the triquetrum, known best for the LT ligament. I think that's probably about it. And those annoying dorsal triquetral rim fractures that really take a long time for people to feel better afterwards.
Yeah, I mean, there's a lot of mystery with the tracheatrum because of those LT injuries. What do you do with them? How do you know they're symptomatic? Like, how often do you see them? And like I've said on this podcast, you can see an LT ligament injury, and yet, do you need to treat it other than arthroscopically debride it? Do you need to fuse the joint? It's an interesting bone.
I think that LT injuries have seen me more than I've seen them, but I don't see them very often.
That's fair. And then we should save a minute or two to talk about carpal dynamics. I think that would be interesting. Um, yeah, and then those dorsal triquetral fractures, which usually are seen only on a good lateral, and the pain is perfectly reproducible over the triquetrum. And your treatment of choice, I usually honestly cast people for 3 or 4 weeks to calm things down and transition to a splint, but you can immediately go into a splint. It just depends on the patient.
Yeah, I just do uh, I do a removable wrist brace, cock up wrist brace. You know, I've learned to counsel people that those take a while to feel better, about 3 months typically. It's just it's interesting. They come in with their noted epic saying left wrist fracture, and you're like, oh, excited. Maybe it's like this radius or scaphoid, and it's just a trapezial, or excuse me, a triquetral dorsal rim fracture. Not fun.
Yeah. Yeah, and it also comes into play with the PRC, proximal carpectomy, when you're trying to get all the way over there to take it out, while obviously being careful. But yeah, its neighbor, the lunate, is far more relevant.
When you do a four corner fusion, um, how much attention are you paying to that triquetral hamate articulation, and how much of an effort do you take that down, and do you put a screw across that too, or whatever your choice of fixation is?
It's interesting. I've done far fewer four corners recently. And by recently, I mean the last couple of years, which is, a big part of your career, but a very small part of my career, a couple of years. I take down I think this is debatable. It's a great question. I do pay attention to it. I take down the cartilage of the tracheal hamate joint, and my home run screw is created from a separate incision on the ulnar side, and it goes tracheum hamate capitate. I love that screw. Can't always get it based on anatomy, but usually you can, and I think it's a great screw and it makes me feel good.
When you make that incision, which I do the same thing, do you find a dorsocutaneous branch of the ulnar nerve, or do you just bluntly spread down?
My general philosophy is I would be happy to see it, and I would say I almost always see it, but it's also okay to not see it, meaning know that it's not in my pathway.
Do you ever try to get that
Is
screw
that
in through?
sacrilege? Did I just
It's
speak to a
fine. You
nerve
might
guy?
you might be one of the guys who wrote one of the seminal papers on CRPS. For some reason, you're the senior author in that one. Well done on that. But yeah, that's fine. I mean, I like to see it, and they usually do see it. But I'm not making the incision much bigger to go find
Does it like make it a great day when you see a nerve like that? Like, are you take a
it.
moment for everyone in the
It's a
room
teachable
to
moment. It's a teachable moment. Do you ever try to get that screw through the dorsal incision? Because I think that angle is really hard to get to drop your hand enough to get that perfect quote home run screw.
totally agree. That's Calfee's approach. He does it through
Yep.
that dorsal incision. No, I do not. And funny story about being senior author on a CRPS paper. Dr. Gelman really wanted me to be the senior author because who wants to be the senior author on a CRPS paper? No one wants to be known for that diagnosis.
Well, it was picked as a classic article for for one of our fellows. Picked it to discuss. We're actually interesting. We're doing a little tweak to the journal club format. We'll see how long it sticks around, but we're going to do a classic from the Stern folders, and then a contemporary major study that may support or refute. It should be good discussion tomorrow. I think last time we had a nice discussion on the articles too. So.
Yeah, should be. All right, we have three more bones and one dynamics concept to discuss. So the lunate. I think the lunate gets a lot of love.
I think the lunate and the scaphoid get a lot of love. I don't think we spend a lot of time on those topics here. We should talk about dynamics and then talk about our old friend the trapezium.
Okay. Well, let's just talk about why the lunate gets love, why the scaphoid gets love. So the lunate gets love. I'll give maybe one, you give one. We'll go back and forth till
Sure.
we can't think of any anymore. Lunate avascular necrosis or Kienbach's is a challenging issue. It's also the topic of one of our little
Mm-hmm.
discussions for Journal Club. Yeah, so lunate AVN is one.
So obviously for AVN of the scaphoid, so prisers, again a much less commonly presenting condition. But then we always, for the lunate, we talk a lot about scavolunate instability. And I think that's one area. And then there's perilunates injuries, which are highly testable and always show up and can show up on things like 4th of July.
Yes,
Remember
they
seeing
can.
those blast injuries? Yep.
Yes, they can. Two more. One would be along with perilunate, the vascular leash from the, volar lead to supply the lunate. And I would say the other is the almost universally preserved radiolunate joint, meaning when you have wrist arthritis, as Kirk Watson taught us, it's very, very rare to have radiolunate arthritis.
Yeah, no, I don't see it often in that, barely ever see it in that context. It's usually in a more either an osteoarthritis or an inflammatory arthritis setting in which you'll see radiolunate wear.
Yeah. And on the other end, on the distal side, of course, you can have it as part of a slack or snack wrist. You can have capital lunate arthritis. Um, yeah, it's an interesting bone. Not my favorite bone by any stretch. It never would be. It's not top three.
And then the scaphoid and all of its peculiarities with its blood supply, coming in dorsally, and then the most proximal aspect, proximal pole being at risk for its own avascular necrosis. Um, Again, we can have a whole episode just on scaphoid fracture fixation alone. I think that the reason why the scaphoid and the lunate are so important is I like to describe it to patients as are like the cornerstone or the keystone of the wrist. The two most important bones in there, and once they usually are linked together quite tightly, and they usually move together. And when something happens where they can't move together, that's when all the alignment is thrown off in the wrist, and that can lead to things like arthritis.
Yeah. Yeah. I mean, we could talk all day about the scaphoid we have before, whether it's prisers, whether it's fracture, whether it's all the secondary ligaments. Yeah, interesting bone, interesting shape, interesting blood supply.
How often do you, in the setting of if you're doing a scaphoid excision four corner fusion, how often do you get the scaphoid out in one piece?
While I never make an effort to take the trapezium out in one piece for CMC treatment, I generally make an effort for the scaphoid. But I would say I'm 50-50 on it. What about you?
I'm not 50-50. I start with the intention of trying to keep it in one piece just for, I don't know, for some weird pride thing. Sometimes I like to educate our residents and fellows and encourage them. But no, other than that, I mean, do you ever use a scaphoid, the cancellous, as your local bone graft for the four corner?
I would say I will occasionally, but I'm universally disappointed. And I think you can actually harvest reasonable appearing cancellous bone. I just don't think it's as good a bone as distal radius cancellous bone. Just like I don't think distal radius cancellous bone is as good a bone as iliac crest bone. Just, someone has done studies looking at the quality of the bone progenitor cells. It's just better in the hip.
Yeah, no, for sure. I think it was in JHS last year. For sure. I can't remember which center it was. But and then I guess that brings us to the old trapezium.
The old trapezium coming full circle.
Wow.
Yeah. Well, we talk about it as well a lot from, arthritis on its distal surface, arthritis on its proximal surface. How about fractures? I have treated trapezium fractures. Absolutely.
I had an interesting one come up recently. I was actually in clinic with Dan Hong. This was a couple of months ago, but it was an intra-articular trapezial fracture in a very young patient. And I was like, well, there's nothing we can do here I'm not going to fix this. But I did have a counselor just based on principles about the risk of post-traumatic arthrosis. I don't know if this is going to bother you, but just keep that in mind that that's something to think about. I don't think I've ever fixed a trapezial fracture.
Yeah, it's certainly rare, like the other non-scaphoid carpal bones, but possible. Never seen AVN. There's a lot of ligaments that attach to it that we always cut away with impunity.
Just don't cut the FCR.
Don't cut the FCR. Yeah, yeah. I don't.
So for the so you don't try to take out the trapezium in one piece, do you?
I really don't. I see the eloquence in it, and Calfee does every time, or wants to every time. He was taught that during fellowship, and I was taught that during fellowship and promptly forgot it. I just think it cost me time in the OR without notable benefit, without any benefit to the patient.
Right. No, that's true. I mean, I've nicknamed fellows piecemeal or unblock based on their performance that day, and they'll know who I'm talking about. But I try just for fun, and then if it's getting frustrating, then we just move on.
It is an important lesson that really, if you are a resident or fellow attempting to excise the don't excise the scaphoid in this situation, trying to excise the trapezium in one piece, it does teach you about the facets and the morphology of the bone, which is, again, important.
Absolutely. And again, the biggest thing for me is just whatever you do, I don't care if it's on block or piecemeal, just don't cut the FCR. Just I like to leave it as a lifeboat, or you're doing an LRTI, and that's obviously the big part of the game there. So
Yeah. So let's talk briefly about mechanics, and we could probably spend an episode or bring a guest on who can talk about this at length. I think the basics, and for those of you on YouTube, hopefully this is helpful. It may or may not be. When you ulnarly deviate the wrist, and this is super relevant to everything we do, the scaphoid extends. Um, and when you radially deviate the wrist, the scaphoid flexes. It has to flex to have room for the radial deviation posture. And everything that happens on the radial side of the wrist, that is the simple concept that we have to understand.
So in that context, you can use that ulnar deviation move to look for potential, instability. So you're trying to see if or the scaphoid is actually scarred down and flexed down and won't come back up, and that's important because that helps you determine your potential treatment options.
That's right. And I use it when I do a scaphoid fracture surgery. I use that ulnar deviation posture as one of the critical x-rays to understand where my screw is going, including a scaphoid view as well. But it's just a really helpful x-ray and gets to the point of the scaphoid. I have to say, when you go in the radial direction, you get that hamate high position, which actually, I hope I get this right, is when the triquetrum goes distally. That doesn't really change my understanding of the carpus in any fundamental way, but it's just an important concept.
Yeah, and I don't think I've ever intentionally sought out a radial deviation view. But I do like on to your point for the ulnar deviation view is really nice to profile that SC articulation, which I think is a critical part of making sure that we've got the reduction appropriate.
And I think the last thing I have to say on this, and maybe not the final word, but close to it for the pod, is the dart throws motion. Now, you grew up as a resident, I believe, with a
Mm-hmm.
lot of conversation. So I'll turn it over to you to share any important thoughts.
Well, I mean, the concept of the dart thrower's motion, which Trey Crisco, who is I believe at Yale, and Scott Wolf, who was at Yale and then moved back to HSS, did a lot of work on this. The majority of it, I think, in the aughts, and some in the 2010s. But the concept is that the dart thrower's motion which would combine kind of extension, radial deviation, and then uh, ulnar deviation and flexion. Uh, Based on their work, does not put the SL ligament under strain. So theoretically, it is a way to work on wrist motion during early recovery of scapholunate repairs or reconstruction.
Yeah, well said. And our therapists know it and they use it. It's not something I talk a lot about in the clinic, but I think it's an important concept when treating those injuries. So I think that was well explained.
So when you do SL repairs or SL reconstructions, when do you start motion for those patients? And do you start with dart throwers?
I do. Well, I don't start early motion because I believe capsular healing and dorsal ligamentous healing is really important. And so usually I don't start until 6 weeks, and maybe I'm missing a window, but patients get their motion back. So I started at 6 weeks with a volar orthosis, a volar splint, and then it can be removed for dart throws motion specifically.
And when do you move them from dart throwers to unrestricted wrist motion? Does it matter, you think?
I don't know enough to say whether it matters. I usually make that transition in a little more aggressive therapy at 8 weeks. So a couple weeks of isolated dart throwers.
Okay. And then when, just to complete the discussion, when would you allow strengthening?
Depends on the situation, but usually by 10 weeks for sure.
Okay. All
What
right.
about you?
I think I'm pretty similar. I don't do enough of these to truly have a protocol, but I usually don't, just in general, don't do strengthening until we've got a good base of motion. So a pretty reasonable arc of pain-free motion. But yeah, no, I don't do enough to have a true strong feeling about it.
Well, I'll close by saying thanks for the suggestion for this podcast episode, and for those of you who are hopefully logging on to complete the questionnaire and the survey. Thank you, and hopefully you'll submit an episode too. Carpal anatomy and carpal bones, more fun than I knew they could be.
Oh, so much fun, so much fun. So again, please do the listener survey, email us at handpodcast@gmail.com, and make sure to if you have any other feedback, ideas, leave a review. Certainly helpful for us. And Chuck, I hope you have a great rest of your Sunday. I'm about to go grill and chill.
Grill and chill all day long. Have a good one.
You take, see ya.